Welcome to the Researched RN podcast. I am your host, Steven Cuzmenco. In this podcast, I discuss new and interesting peer-reviewed research articles from various nursing researchers and other professional publications. In this 7th episode, I'll talk about an article published in the Journal of the American Heart Association titled Sex Disparities in Resuscitation Quality Following Out-of-Hospital Cardiac Arrest. It's authored by Disparities and colleagues. To start off with the background, we know that women are disadvantaged in certain aspects of resuscitation care compared to men, especially when it comes to surviving out-of-hospital cardiac arrest. They are more likely to have an unwitnessed out-of-hospital cardiac arrest, which can delay initiation of CPR and also contributes to the fact that they are less likely to receive bystander CPR and public application and use of a defibrillator. Evidence suggests that women are less likely to also receive targeted post-resuscitation care and more likely to have resuscitation efforts ended sooner. When it comes to improving resuscitation care for women, the authors explain that focusing on the pre-hospital setting, or EMS, emergency medical services, is an important step because their decisions largely influence where cardiac arrest patients go and the subsequent care they receive. So, the aim of this study was to, quote, examine sex-based disparities in EMS resuscitation quality and processes of care for out-of-hospital cardiac arrest, end quote. Jumping into the methods, the study design was a retrospective analysis of EMS cases from the Victorian Ambulance Cardiac Arrest Registry in Victoria, Australia between March 2019 and June 2023. Patients were excluded from analysis if their sex was not recorded, if their age was under 16 years, if they had an advance directive of do not resuscitate, if the cardiac arrest was precipitated by a traumatic event, and lastly, they were excluded if the cardiac arrest was witnessed by EMS personnel. A little bit on the setting where this study took place. So we know that it's pre-hospital EMS personnel in Victoria, Australia. Ambulance Victoria is the provider of emergency medical services, as I stated, in Victoria, Australia. I've actually been there. It's a great place to visit. This state in Australia has a population of 6.5 million people. When someone in this community needs to call for EMS to be dispatched in the event of an emergency, the person calling receives telephone CPR instructions while the ambulance is en route. They also have a smartphone alert system where volunteers can be notified via an application on their phone for any nearby cardiac arrest situations that they can potentially respond to. The paramedics that respond to emergency calls are trained to use high-performance CPR that prioritizes rapid defibrillation and minimal interruptions to chest compressions. Their equipment also includes defibrillator pads that includes feedback information, so they are notified in real time of their CPR quality, which includes chest compression depth, chest compression rate, recoil velocity, and pauses during the emergency response. The data obtained from the defibrillator is then uploaded to a central database. And also, part of the EMS team, there is a dedicated resuscitation coordinator that audits all of the out-of-hospital cardiac arrests, where they are able to take a deeper dive into the performance metrics based on the information included in the patient record and, of course, from the defibrillator. Also included in the Victorian Ambulance Cardiac Arrest Registry is patient information, which includes the sex. This is recorded by the treating paramedics that have a drop-down selection of male, female, or other/unknown. The outcomes of this study included a total of 18 metrics across 5 performance domains. And here are the results. There were a total of 10,161 out-of-hospital cardiac arrest cases included in this analysis. The majority of these cases, 68%, were men. Initially, the authors point out that the baseline characteristics of the women included in this study were less favorable. What do I mean by that? On average, the women that experienced out-of-hospital cardiac arrest were older and more likely to present in non-shockable rhythms, which in terms of cardiac arrest survival is generally associated with decreased survival. As we go through the results, one thing I really liked about how the authors laid out the data is in the domains of the cardiac arrest chain of survival. These are the 5 domains that I mentioned earlier, and they include early recognition, quality of chest compressions, defibrillation, advanced life support interventions, and post-resuscitation care. You can actually find this chain of survival if you just Google AHA chain of survival. When it comes to the first link in the chain of survival, early recognition, the median time from arrival to placement of defibrillation pads was 1 minute for both men and women, and so there were no sex-based differences observed here. ECG rhythm recognition was accurate in 93% of patients, and there were also no sex-based differences observed here. For the second link in the chain of survival, chest compression quality, the median chest compression rate was 115 compressions per minute. There were no sex differences observed between men and women when it comes to the rate. Additionally, chest compression depth analysis showed no difference between men and women. A difference was noted for chest compression fraction, where it was slightly higher for women at 92% versus men at 91%. And so this is a very small difference, but it's noted in the results. In regards to chest compression recoil, it was observed that this was slower for women compared to men. This is a newer term for me, and the unit of measurement is millimeters per second. So the higher the number, the more complete the recoil is during CPR, which if you are a resuscitation instructor, you know this is a very important aspect of high-quality CPR, appropriate or adequate recoil. For the third link in the chain of survival, defibrillation, the median time to first defibrillation was 2 minutes, and the median pre-shock pause was 5.7 seconds. For both of these metrics, there were no sex-based differences observed. In contrast, when it came to the post-shock pause, this was actually shorter in women at 3.4 seconds compared to men at 3.6 seconds. Moving to the fourth link in the chain of survival, advanced life support interventions, the median time from EMS arrival to insertion of a supraglottic airway device was 3 minutes, and first pass intubation success rate was 83.7% for the overall cohort, and there were no sex-based differences observed for either of those two outcomes. Although in contrast, time to epinephrine administration was longer for women at 8 minutes compared with men at 7 minutes. If you've ever been in a cardiac arrest situation, 1 minute is a really long time. So to me, this is pretty significant. And lastly, for the fifth link in the chain of survival, post-resuscitation care, across all performance metrics, post-resuscitation care was worse for women compared to men. Women were less likely to achieve a systolic blood pressure of greater than 100 upon arrival to the hospital. As reported, 91.6% of men achieved a systolic blood pressure greater than 100, in contrast to 87.2% of women. Women had a longer median time of acquisition of the 12-lead ECG after return of spontaneous circulation. In men, the median time to 12-lead ECG after ROSC was 5 minutes. in contrast to 6 minutes for women. The authors pointed out that this meant a higher proportion of women received a 12-lead ECG after loading onto the ambulance while en route to the hospital. To me, I don't think this would be a major issue if your EMS personnel are extremely proficient at interpreting a 12-lead EKG while in a moving ambulance, looking for the presence of any acute coronary syndrome. But when it comes to alerting any kind of cardiac catheterization lab prior to arrival of a known or suspected acute coronary syndrome, this is information that you need to know as fast as possible. Which coincidentally, or not coincidentally enough, the authors observed that women were less likely to be transported to a 24-hour percutaneous coronary intervention or PCI-capable facility compared to men. 92.3% of men were transported versus 88.5% of women transported to a 24-hour PCI-capable center. And lastly, for patients who did not survive cardiac arrest and died on the scene, the median time for when resuscitation efforts were terminated was much quicker for women compared to men. The authors reported that it was 14 minutes for women and 24 minutes for men. So it seems like women did not get as much time of resuscitation efforts when it compares to men. And so now we get to move on to the discussion and take-home points. So this study highlighted significant sex-based disparities when it comes to out-of-hospital cardiac arrest patients in Australia. And so it is important to note where the information is coming from. This is not information obtained from an American population or a British population or a Swedish population and so on and so forth. So just keep that in mind when you read this article. But we did find from this study that resuscitation efforts for women were terminated earlier than for men in cases where spontaneous circulation was not restored. We also found that women were 34% less likely to achieve a systolic blood pressure of greater than or equal to 100 upon hospital arrival. Additionally, women in this study also experienced a longer time to 12-lead ECG acquisition after ROSC, which may have contributed to the 33% lower likelihood of them being transported to a 24-hour percutaneous coronary intervention capable facility. It's a facility that allows them to respond to heart attacks, myocardial infarctions. And so related to the previous point, of women being less likely to achieve a systolic blood pressure greater than 100, the author suggests that severe hemodynamic instability could have contributed to them being transported to a closer hospital rather than a farther PCI-capable facility. So this is just a conjecture. This was not something that was officially reported in the results of this study, but them just trying to explain maybe this is why we're seeing this. But in the same paragraph, they also make an argument against that in saying that rapid acquisition of a 12-lead ECG could allow certain goal-directed therapies to be initiated, such as anticoagulants and thrombolytic therapy, which those could have assisted them in stabilizing the patient's hemodynamic status, which could have in turn facilitated a longer transport time to a PCI-capable facility. So there's clearly much that is still yet to be understood in this realm. And I mentioned very early on that the baseline characteristics of the women in this study that experienced out-of-hospital cardiac arrest were less favorable in that they found they were more likely to be older and experience cardiac arrest in residential care facilities, which may delay recognition and activation of EMS. And so in contrast, let's say they were more likely to arrest in public and have it be witnessed, that could enable them to receive bystander CPR. and bystander CPR is better than no CPR. And so some of the limitations of this study were that the patient's sex was based on the paramedic's assumption as opposed to the patient's stated sex, which could have been different. Another limitation is that the patient records were derived from retrospective recording of paramedic interventions, which could have led to inaccurate information being included or excluded. But the authors suggest that this type of bias should be random across both sexes if it were to occur. Other confounding variables that were not measured in this study were patient frailty and comorbidities, which could have influenced paramedic decision-making in response to cardiac arrest, which also could have contributed to the shorter time of resuscitation efforts found in women compared to men. But of course, this is a limitation. This information was not obtained from this study, so therefore we cannot know that for sure. And in conclusion, the authors suggest that future research should prioritize the underlying causes of the observations of this study, including potential bias and decision-making during resuscitation efforts. Additionally, they suggest that EMS personnel should receive targeted education to raise awareness and address implicit bias that can contribute to these disparities. And so as we finish up this episode, I'd really encourage you to read this article and look at the main aspects of sex disparities in out-of-hospital cardiac arrest. I'm sure that there are other articles that talk about this in other geographic parts of the world, so it'd be interesting to compare what's happening across the world. Of course, you're listening to this episode, and if you teach life support or resuscitation courses in the hospital or community settings, this is really important information for you to share with your students or your participants. If you know someone who teaches life support or resuscitation courses, this is a great podcast episode for you to share with those people so that they can integrate this information into their curriculum, into their content. We should all be advocates for improving population health and moving towards a more equitable and effective resuscitation care system, not just in Australia, but all across the world. And of course, there are limitations when it comes to availability of personnel, availability of training equipment, availability of healthcare services, but we should all be the best that we can be with what we have. And that is a wrap on the 7th episode of the Researched RN podcast, your virtual journal club on the go. I am your host, Steven Cuzmenco. I'll have new episodes out at least monthly. You can email me at researchedrnpodcast@gmail.com with any topics, articles, or suggestions you have for the show. Thanks for listening, and be sure to tune in to the next episode